The recording has started. So,
I told you I had to do a Zoom.
So, and then just, all right, so the recording has started. So,
I told you I had to do a Zoom.
So, and then just as a quick reminder, if you could keep your mics muted, that would be helpful as well. So thank you very much. So we want to welcome you all to our grand rounds today. It's going to be very interesting to see. All right, so the recording has started. So,
I told you I had to do a Zoom.
So, and then just as a quick reminder, if you could keep your mics muted, that would be helpful as well. So thank you very much. So we want to welcome you all to our grand rounds today. It's going to be very interesting to see this as we're having 3 different organizations present at once. And that's not something we've done in the past. We've always had one do it. So this is going to be new for us. I'm really excited though, because having seen the content, it's very dynamic. What we're looking to do is go over what it means to use the DHIN and DMOST electronically, because with everything going on right now with the pandemic, that is becoming critical for us. That we need to be able to be flexible and meet people where they are, but then also have access. Oh, there's Dr. Goodall. Your timing is excellent, sir. All right, so just a quick introduction to who we are as the Delaware Quality of Life Coalition. The Delaware Quality of Life Coalition started as the Delaware End of Life Coalition in 2000. There were a couple of people who came together because of just not being satisfied with where end of life care was currently in the state of Delaware, and specifically how that conversation was going. So they formed the Delaware End of Life Coalition and started to advance the conversation. Fast forward 15 years, the Healthcare Commission established the End of Life Work Group in November, and out of that work group came recommendations of what we needed to do to take things even further in the first state. And the culmination of that was the identification of the coalition as the right work group to carry this forward. So that being said, we changed our name from the End of Life Coalition to the Quality of Life Coalition, and we are the primary entity responsible for coordinating efforts related to palliative and end of life care in the state of Delaware. So our key activities are to do things like this, promote educational opportunities, but also to support the inclusion of end of life and palliative care issues in what DCHI is doing, and making sure that any of the curriculum that the schools are using is all inclusive of what truly is hospice and palliative care. We do help inform as legislatures do policy revisions, and we are constantly working on awareness campaigns, some of which has brought you guys to this meeting today. So that is the fast and furious version of what the coalition is. And with that, I am going to turn it over to Dr. Goodall to give us an overview of DMOST. So Dr. Goodall, I will be your Vanna, sir.
Thanks, Keegan. Appreciate it. So I'll just tell you when to advance the slides. Is that how we're going to work this?
Yes, sir.
Well, welcome everyone. I see there's like 65 people on this call. That's wonderful. I think the overall goals tonight is to kind of review the best use of the form that we have available here in Delaware called the DMOST form, and also to get people more familiar with the registry and how to begin using that a little more than we have in the past. We'll show you that we've had sort of a slow startup to that registry, and we want to try and pick things up a little bit. I want to thank my fellow presenters. We have Dr. Sarah Matthews and Nicole Fulmer. Sarah Matthews practices down at Beebe Hospital. She's a palliative care physician, and Nicole is the executive director of Honoring Choices Delaware and works at Delaware Hospice. And I'll let them tell you what they're going to talk about actually. But I'm going to start things off with just a very brief overview of DMOST, and then a basic how do you use the registry. So Keegan, can you advance this, please? So DMOST, I think you all know, is basically an advanced care planning tool. And as you all know, you can use tools appropriately or you can misuse them. And we really want to see this form being utilized in the best possible way when it's appropriate to lead to better outcomes for patients and families. You all know that this is not for everyone. It's really aimed at a select population who is near the end of their life, usually within a year or two maybe. They're the persons that can really see what medical treatments are going to be helpful to them and which ones aren't, and hopefully they can complete a medical order form like this and get the medical treatment that they want. So it's a medical order form, and there's a lot of evidence in the literature that shows that this type of a tool is more effective than run-of-the-mill advanced directives in getting people the medical treatment that they prefer near the end of life. And then this whole effort is really supported by a organization, a national organization called the National POST, which helps promote this type of a tool in all the states across the country. And so you can go to post.org and learn a lot about the program around the country and all the different states. Advance, please. So I think you all are probably aware that this form is supported by a state law, a statute that was passed in 2016. And you can go into the state statute on healthcare decisions and see it as Chapter 25A. And really this is, that's wonderful. There was a lot of effort put into getting that done. And it really helps us in utilizing this form across the state in a standardized, uniform way, and people will begin to recognize it and act accordingly when they have one in front of them. The DMOST has a program, though, that is really charged with helping to promote and then monitor the use of this form across the state. And it was given to the Delaware Academy of Medicine initially, and they did it for 2 years. And part of what I'm going to show you today is some of what they did. And then the DHIN also partnered with a vendor called Vinca to stand up the registry in 2018. And as we'll see, it's been kind of slow to get utilized, but we really are one of a few states that has a statewide registry for this form. And so I think that it's a good idea to certainly be aware of it and then begin to utilize it appropriately in our work. So the DMOST program now resides with this nonprofit organization, the Delaware Quality of Life Coalition. And as we'll talk about a little bit, we really need to put some work into it to get it to be doing what we want it to do. Next slide. So what a DMOST program consists of is training, education for both providers and the public, the encouragement of the appropriate use of the form, some of what we're doing here tonight, but also monitoring and troubleshooting problems that arise with the use of the form. And we're going to mention a few of those in passing also here. And then obviously with the statewide registry, we want to grow the use of that and sustain it into the future, which is an issue actually. And then utilize that data that we can gain from a statewide registry for quality improvement, performance improvement kinds of activities. Next slide. I'm going to try to get through this quickly because I want you to actually look at the video that we have. So this is the form, and I think you all are familiar with it. As you can see there, to be valid, it has to have these 4 items: a visible watermark, which is a little bit of a problem, and we can talk a little bit about that. But internal consistency, obviously what you check off has to make sense from a medical standpoint. the signature blocks have to be properly completed and no additional markings. It really consists of 6 different sections, A, B, C, D, E, and F. Next slide, Keegan. So one of the problems that I've seen a lot with the DMOST form is this section E, which is you're supposed to document who the orders were discussed with, whether it was the patient themselves, the surrogate by this Delaware surrogate statute, or agent by previous healthcare directive. And then that person's name goes on this line here. But this section up here is for the name of the person who went over all of the form with whoever was signing it from the patient standpoint. So it might be a social worker here. It might be the physician or the nurse practitioner or the PA that signs down here. And if it's the person that signs down here, you probably don't need to duplicate their name up here, although you could. But if there's a different facilitator, their name should go up here, and then obviously can only be completed by a physician, nurse practitioner, or PA who signs down here. It's been my practice to get certainly identify who the surrogate is. If it's the patient you're talking to, you want the patient's signature. I often do this with the patient and the surrogate and get them both to sign here, and that's okay too. I think that this other part is a little bit problematic. If I lose capacity, my authorized representative may not change or void this DMOST. If the patient wants that to be the case, they have to sign here. So that's another extra signature you have to pay attention to. I usually don't recommend this for patients because I think they usually want their surrogate to be able to respond to the situation at hand, and they may need to tweak the initial form that was completed in various ways. So they can't do that if the patient has signed it here. So next slide. So those are it's kind of a problematic section, I think, and a lot of people don't know what to put in, especially in that area. So there are some problems with the DMOST program too, and that's what I'm hoping some of the callers on this call can help us with, and that is we need to reconstitute the steering group that helped get the DMOST put into statute in the first place, with a lot of different stakeholders across the state to help guide us into the future with the use of this form. We could use at least a part-time coordinator for a lot of the type of things we want to be doing with the DMOST form. We obviously need resources. We do have a link to the National Post. I'm the state representative to the National Post, and Keegan is involved on their technology committee. So we do have some connection there, but we want to be we want to be able to be approved as a endorsed state, and part of being an endorsed state is having a viable program to shepherd the form and the efforts around the form. And obviously sustainability is a big item going forward, because I'm not going to be here forever. A lot of you are not going to be here forever, but we want this to be able to go into the future in a strong sort of way. Next slide. So this is a slide from the DHIN's vendor partner, Vinca, and it looks at the activity for the registry for the month of November, and there are some cumulative totals here too. So if you look at here, and it identifies various organizations and activities throughout the state, and lists the number of accounts they have and the number of those accounts that have been activated. Now, account is when a provider at that organization is identified by the DHIN as a person who can use the registry, and then it's activated when the provider actually does use the registry. So you can see here, Christiana has 34 accounts and only 19 of them have been utilized. Delaware Hospice is the 800-pound gorilla here. They have 173 accounts. 83 of them have been active. So on down, you can look at all of those numbers. The hospices have been the most active groups in the use of the registry to date. This is only the November total, so those are going to be small numbers, but this is the cumulative total. And you can see here that most of these DMOST forms in the registry have been uploaded. They've been paper forms that have been uploaded to the registry. That's what this column is, 600 of them total. And this is the number of electronic forms that have been created. You can see Delaware Hospice again is the leader in this, but only 44 of them to date. And this is the number of times that the registry has been accessed, 1,500 to date, and that's over a couple of years now. So I think what we're trying to get to tonight is getting more of these accounts online, more of them activated, and beginning to get people to utilize the registry to actually create some electronic DMOSTs, and also learn how to upload them too. Next slide. Oh, go back to that slide there for a minute, Keegan. So this number here, tenant administrators and organizational administrators. So there are, in order to get an account, you have to have an administrator at your organization verify your credentials with the DHIN. And so you would identify somebody at your organization who would be in touch with the DHIN and working to identify all the users of the registry in your organization. And then as a provider, once you're on there, once you're approved for that with your organization administrator working with the DHIN, then you simply go on the DHIN website and pick a password, and then you're an activated provider of utilizing the registry. So the tenant administrator are people at the DHIN that work with these administrators to get people on activated in these accounts, or get these accounts in place so that providers that can then activate them. Hope that makes sense. If not, I think they're one of our colleagues at the DHIN may be on the call, and we can come back to that in the questions. So creating a DMOST, I think just some sort of best practices here. I think we mentioned it's in the setting of serious illness with a life expectancy of about a year. It's executed by the person themselves and or their surrogate. Best practice is use both of them if you can. But the nice thing about it is when a really sick person does not have decisional capacity, you can still complete one of these with the surrogate and to hopefully deliver the best care for that individual patient. And the healthcare provider that completes the form has to be either a physician, nurse practitioner, or PA by statute. The emphasis is on the process of communication and conversation and decision making that really fully informs and empowers the best result. So if you don't have a good conversation and you're not talking to the right person and you fill out one of these forms, it's nothing better than junk. And unfortunately, sometimes we see that, and they have to be avoided and redone or completely turned over and not utilized. The key thing is, how can you build this into a workflow that works for everyone? Because it takes a lot of time to kind of go over this kind of a form with patients and surrogates. So if you are part of a team and your social workers are very good at facilitating this conversation, you might have them complete the form or complete most of the form with the patient and surrogate, and then simply have your physician or nurse practitioner or PA executed with their signature at the end. And there are billing codes that advanced care planning codes that one can utilize to recoup some compensation for this time and effort, and we should certainly be utilizing those. Next slide. So this is a video, and I'm hoping that it's going to run from, I don't know, this doesn't look like the slide that I had on here. Is there another slide? Can you? No, go
No,
to
I embedded the video, Dr. Goodall.
Pardon me?
To run smoother. Oops. Come back to her.
Is this
Yep.
going to run? Can you
It will
click on
run
that?
as soon as you say go.
Okay, so let's run it. If it starts at the beginning, we're going to move it forward just to the electronic portion of it.
This presentation will discuss the electronic Delaware Medical Orders for Scope of Treatment form and the online registry found at DHIN.org.
So this video is actually on the DHIN website. And Keegan, can you move this forward to like to about 5.5? Keep moving it. Okay, there, good. Start there.
Is assumed.
Thank you.
The electronic DMOST form can be found on the Delaware Health Information
All right, everyone, be
Board
patient.
website, DHIN.org.
And pay attention, please.
This presentation will cover how to access the online registry, look up an existing DMOST form, void an existing DMOST form, complete a new e-form, and upload that form to the registry. It will also cover how to print out the form and frequently asked questions for patients and their families. To access the online registry, go to DHIN.org and select Healthcare Providers, then scroll down to DMOST Registry. To access the online registry, go to DHIN.org and select the Healthcare Providers menu, then choose DMOST Registry. To access the registry, scroll down the page. You will also find a PDF of the DMOST form and frequently asked questions. Click the link to the registry and input your username and password. In order to look up a patient's existing DMOST form, the first step is to find the patient in the DMOST registry. Input as much demographic information as you know and hit search. If a patient has a DMOST form in the registry, their name will appear, and you will be able to see their current form as well as any voided forms the patient had previously. This patient does not have an active DMOST, but she does have an incomplete form, waiting for a healthcare provider signature. In order to create a new form, and thus void the old form for this patient, all you have to do is select Start a New DMOST. The e-DMOST will take you through the same sections as the paper DMOST. The first section you'll come to is the Goals of Care section. This section outlines the specific goals of care that a patient is trying to achieve. This is not medical orders. Use this section to help guide the patient's answers for the rest of the form. The following sections have logic built into them. So if you say, we're going to attempt CPR for this patient and accept it and continue, the only thing that you can choose in the next section is full treatment. This is internal consistency of the DMOST form and has to be there in order for the form to be valid. If, however, you choose DNR, do not attempt, and go forward, then you can choose the other options. Another option in limited treatment is transferring to the hospital for certain medical interventions, and you can also choose comfort-only measures. You can put other orders in here too, like dialysis or blood transfusion orders if needed.
The voice you hear here is Dr. Kate Smith, who works for the Delaware Academy of Medicine.
Artificial hydration or nutrition. There are also options for defining a trial period for this type of care. In this section, you need to identify the people participating in the planning discussion. At the very least, even if they do not have decision-making capacity, you should be talking with the patient. Their authorized representative should also be present. This representative can be the patient's power of attorney for healthcare, their surrogate, or their guardian appointed by the court. It may also be the parent of a minor child. Next, you put in who the authorized representative is and their relation to the patient. And again, in this case, the street address will automatically start filling in once you start writing it. At the bottom of this section, you're going to ask your patient if they lose capacity, if their authorized representative has the ability to change or void their DMOST form. Depending on what the patient says, you're going to choose whichever option. And now we come to the patient's signature about whether or not their authorized representative may change the form. So you can either click to connect to a mobile device, an iPad, an iPhone, or an Android phone, or an Android pad of some kind, or you can have the patient sign with the mouse on the screen. And you accept and continue. If you choose to have your patient sign by way of a cell phone or tablet, click the link on the DMOST that says, "Click here to connect to mobile or cell for signature." Your device will receive a text message like this one. Click the link within the text message to connect your device. You will receive a 6-digit confirmation code on the device. Input that code into the DMOST pop-up window. You will see a box on your cell phone or iPad that says sign your signature here, and you can just do it with your finger, and that signature will show up on the screen wherever you're filling out the form itself. Next, the person preparing the DMOST needs to fill out their information. In this example, the preparer is signed into the registry as a nurse, social worker, member of the clergy, or any other member of the healthcare team. They select their name, and they put in their phone number, and then they can sign either via a mobile device or with the mouse. Now if you're on with a mobile device, then that is going to continue to be accepted. You don't have to keep doing it every time you need a signature. The next person to sign is the patient, and you can do it via the mobile device that you've been using or with the mouse again. And you'll notice that the date that the patient signs automatically fills in. So accept it and continue. And because this person, whoever they are, is signed in as just a preparer, not a provider, you're going to get this error message. So the preparer has done as much as they can do. So you can either stay on the page and double check that you've got everything going on that needs to be done. You will be asked for more patient information just to make sure that the patient is who they say they are and you have the right patient with the right form. But you will continue to get this if you try and go on any farther. So for the preparers, their job is done. In order for the DMOST form to become executable, a physician, APRN, or PA must sign it into medical orders. This is the final signature needed on the electronic form. So the physician will fill out his or her information, and you have to put in your license number. And again, if you're using a cell phone or other mobile device, you'll still be able to sign in, or you can sign with the screen. Now let's say that you're pretty sure that you have a patient who doesn't have a DMOST form on the e-registry, or you have a patient that you know doesn't have a DMOST form. Again, you're going to put in as much information as possible about the patient to make sure that there isn't anybody already on the registry with that name or with that information. If no patient is found, you simply have to add a new patient, and you put in as much information as you know. The street address will automatically fill in when you start to type. And all of this information is so that DHIN can make sure that they are matching the correct patient with the correct forms. Once you've added your new patient, there's obviously no active DMOST found, and you can start to create a new one for him. Once you've finished creating the eDMOST for your patient, you can go onto their dashboard, and the first thing that you see is the main things that they do or do not want. So in this case, we do not resuscitate, we only want comfort measures, no nutrition. And you can see the current DMOST form as well as any prior DMOST forms that the patient may have had. If the patient decides they want to void the old form and make a new one, all you have to do is hit Start a new DMOST form, and it will take you through the process again. If the patient, however, wants to void their form and not make a new one, there is an option to void and remove the form here. This form here can be printed out and given to the patient along with their frequently asked questions. All users that are assigned the role of either signer or preparer will also have the ability to upload paper DMOST files. To upload a paper document, first sign it to a computer, then sign into the DMOST registry and search for the patient. If the patient is not yet in the registry, add them. Once on the patient's advanced care planning dashboard, simply choose to drag or browse a document to upload. The registry will perform several checks to ensure the paper form and the patient match, but then your paper form is on the registry. The DHIN recommends that an organization upload their paper DMOST files. All users with the role of signer or preparer will have this ability. If you have any questions or concerns about the upload functionality, please contact the DHIN service desk at 302-480-1770 or email servicedesk@dhin.org.
Okay, thanks for getting through all that. Hopefully that's pretty self-explanatory. And I'm going to turn it over to the second part of our program here tonight. Nicole Fulmer is going to talk to us about Delaware Hospice's experience, and she's going to be followed by Sarah Matthews, who's going to talk about her experience down at BB. So thank you, Nicole, and take it away.
All right, thank you so much, Dr. Goodall. You can go to the next slide, please. About a little over a year ago, Delaware Hospice set out to embark on a journey regarding advanced care planning, and specifically with the DMOST and the DHIN. Just a little bit of background. From our perspective, we are and still continue to be committed to ensuring that everyone's end-of-life wishes are respected and honored. And we wanted to try to find some ways to eliminate the delays, making sure that everyone, all providers, could get access that they needed quickly and easily for patients. And then in working with the DHIN, Eddie Seaton and also with Vinca, just looking for ways to see how we could continually evolve and innovate. Next slide. So over a 2-month period, last November and December, we set out for 2 goals. One is to just ensure, again, that all the providers could quickly and easily get hold of the information needed, particularly if there was a crisis or an emergency situation. And we wanted to take the DMOST forms that we had on our EMR and upload them to the DHIN. Next slide. The process was quite simple. We did need to tweak it a little bit. There was a report that we needed to fill to find all of our active patients with the DMOST. So we just had to create a new user field with a completion date. And then once we had that ready, we just uploaded the completed forms to the DHIN, and we just marked which ones we had done that to so that we would avoid any duplication. Next slide. We were really pleased with the results. So almost 100 paper forms were uploaded in less than 2 months. So our medical records group did a phenomenal job getting this in, just to make sure that all the providers had the information that they needed, again, particularly if someone presented in the ED. And then our field staff would be able to look and see who did and did not have a DMOST on file. Go ahead, you can go to the next slide. So we were really pleased with the results, and we wanted to see what can we do next. So we looked to the electronic process. So we put together a training program to make sure that all of the clinical staff were aware of how to do this. I do want to point out that this was during COVID with everything else going on, and the staff did an amazing job. We kicked off the training April 23rd, and within 24 hours, we actually had our very first electronic DMOST uploaded to the DHIN. Next slide. So as you saw in a previous slide, we're very pleased that we have 280 DMOST right now on the registry. So again, this is about a 12-month effort. And right now, we do have our staff that's completing them electronically. About 80% of them right now have the direct feed into the DHIN that were electronically done. And again, there's no need for a manual upload. Next slide. So I just wanted to comment on a few next steps for where we're headed after this. Of course, we're going to continue to advocate for patients for their preferences for end-of-life care, and continue to complete the DMOST and get them onto the DHIN, as many as we can do electronically. And through my work with Honoring Choices, Honoring Choices Delaware, we want to really educate the community on the importance of advanced care planning and work with providers to make sure we also get the advanced directives onto the DHIN. So thank you very much for allowing me to share that. And I'm more than happy to share our training program, some of the processes and guidelines that we did put into place. But once you put your mind to it, you get everybody on the same page, you have the patients in mind, we were able to do it. Thank you so much. Dr. Matthews, I think you're up next.
Thanks, Nicole. So I'm Sarah Matthews. I'm an inpatient palliative care doc down at BB in Sussex. And I'm just going to take you through how we're using the DMOST in the inpatient setting. Next slide, thank you. So for each new consult we get that we're going to start a goals of care conversation with the patient, it's good to first look, do they already have a DMOST they've completed somewhere else? And so at BB, first we're going to look in our own EHR, and so far, more of our patients will have it within our own system than we're seeing uploaded in the DHIN so far, but hopefully that's going to change over time. And then look in the DHIN as well, and if they don't have one, then you'll see that no active DMOST found. Next slide. With our patients in the inpatient setting, we're having goals of care conversations, which covers all manner of different things that may or may not be appropriate for a DMOST, really centering around who our patients are, what's important to them, do they understand their health condition, who do they want to make their decisions if they cannot, and then certainly code status comes up quite a bit, and decisions about do patients want to go on comfort care or go on hospice. So not every patient we talk to should get a DMOST, but certainly some of them should. And like Dr. Godel was talking about earlier, some of those triggers are a patient that you would not be surprised if they passed away within the next year. Similarly, people with serious health conditions who are likely to have a lot of serious medical events and have a durable post-tax decision that they feel strongly about and they want to be honored. And then a unique one that I've seen come up already in my short time at BB is patients that need to have their decision maker documented because it may not be the person that falls in the legal hierarchy. Next slide, please. So in Delaware, we have a set decision maker hierarchy for someone who doesn't have an advance directive or a DMOST that specifies their authorized representative. Then it will go to their legally married spouse first, followed by adult children, followed by a living parent, then an adult sibling, grandchild, niece or nephew, then aunt or uncle. And a unique situation I've seen is, a patient who has a serious illness and, also qualifies based on, wouldn't be surprised if they pass away within the next year. But to some extent, what they really need is their decision maker documented because, for example, they might have living siblings, but they really have one niece they're close with who they want to make those decisions, and they may not be able to complete an advance directive for various reasons of access or health literacy. So for them, documenting the other areas of the DMOST, but making sure that their authorized representative is specified could be helpful. Next slide, please. The form, like we've talked about already, you've all seen. I will say I haven't found Section A, the goals of care section, as helpful for our patients, just because I feel the goals are often very complicated and hard to fit on a small line like that. For example, someone that might want to be intubated short term for a reversible pulmonary embolism, but does not want tracheostomy or PEG long term because they have an underlying cancer and they know it's not reversible. They're hoping to get to treatment, but ultimately they want to die at home when that time comes. So, except for certain situations, you may not be able to shrink it down to the goals of care line. And then sections B and C are somewhat more straightforward. Next slide, please. Down near the bottom of the form, it gets more complicated, like Dr. Goodall mentioned. I think a lot of patients, the artificially administered fluids and nutrition may not be as relevant to their condition. And I think unless someone has strong feelings about it already, it may not make sense to force them to make that decision in that moment that they're signing the DMOST if it's not relevant to their particular condition. And then I know Dr. Goodall mentioned if I lose capacity, my authorized representative may or may not change or void this DMOST. I do find it useful sometimes. Some patients that have very strong wishes, for example, not to be intubated or resuscitated, and they may find more peace of mind knowing that their family can't go against that if they lose capacity. But I agree, it's a nuanced section. Next slide, please. And then most importantly, really the purpose of this talk tonight, we create these forms, that's great, but how do we ensure that we're actually able to access them in the systems where the patients are, where they need them? How we do it at BB, we are using the paper forms. So we make several copies, give the original back to the patient in that hot pink fuchsia envelope, and inform them to put it on the refrigerator where hopefully paramedics are looking. We upload it into our own medical records, and I don't know about all the other organizations, but at BB that can be a challenge too because we have several different for inpatient and outpatient, so you have to upload it a few different places. And then uploading into the DHIN is actually really easy. So it's that initial screen where you search for a patient and it said no active DMOST found, or in some cases they might have an old one. And then that button, you can see the square box. You'll see that in the lower left of the screen. So it says drag or browse a new DMOST. So how I do it at BB, I just use the scanner. I send the paper form to my email. I open up that file from my email in the File Explorer, and then I just drag it right over to that box right there, and it uploads it straight into the DHIN. So it's super simple. It's actually very fast. Next slide, please. And that's all I have. I think we're passing it over to Alex now for our wrap up.
Absolutely wonderful. Dr. Goodall and Nicole and Dr. Matthews, I think a beautiful walk through step by step. We did have a few comments. I'd also like to thank Eddie Seaton, who I believe is with Delaware Hospice. Apparently you have been a good user of this. I appreciate
Eddie's with the DHIN.
Oh, he's with DHIN. Oh, I didn't realize that.
He's our DHIN plant for the night.
I like it. Well, thank you so much, Eddie, for being our DHIN plant for the evening. We'll take it. I am so grateful for the comments that you inserted in the chat. I like the fact that you do not need to be an administrator to be a DHIN user. There can be assigned people in every location that can do the uploading. It doesn't necessarily have to be the administrator. It just has to be someone who's designated and trained on usage. So thank you for that. There was a question, and I find it an interesting question. I know Dr. Goodall and I think Dr. Matthews, you have both experienced this. I believe maybe Terry has as well. It comes from Janette, and she had a question around how to respond when patients in the hospital that are not necessarily dealing with a prognosis of a year or less are being asked to complete the DMOST. And for those patients that are going from Delaware into other states as well because of the nursing homes requesting it, what is a proper way to respond to these possible inappropriate requests for the DMOST to be completed?
I think that a lot of that is an educational opportunity. Some people look at this form as a DNR form, and so they want that DNR before they transport somebody that they think might code in their vehicle. They want to be very clear about how to handle that situation, but it's not simply a DNR form. And again, it really needs to meet the characteristics we talked about. And the other thing is that for surrounding states, there is reciprocity. So I think DMOST would be honored in most of the surrounding states, and that we should be able to educate people about that. So I think it just requires some education, and that's one of the things that the DMOST program would do more of. I think we haven't really had enough of that in the state. So there are EMS people and paramedics that haven't got the education about this form that we want them to.
I would agree with that, definitely. So we have a few minutes left. Does anyone else have an additional comment or question?
I had a couple of comments, and I don't want to take up all the time, but I wanted to go back to Nicole, and who has done a great job there at Delaware Hospice, and really it was really nice to see that little project that they've done and really become active in the use of the DMOST form. But Nicole, specifically, what do your staff use in terms of tools? Do they have an iPad that they complete a DMOST with the patient and family, or can you give us sort of a little bit of the nuts and bolts about how they do an electronic DMOST?
I believe that they are using their phones and surfaces.
Okay, because I would think that it's kind of hard to look at this form on a mobile phone, but maybe I'm mistaken.
Yeah, I think for the most. I'm so sorry.
Go ahead.
But I do believe that for the most part, it is the surface.
Okay, because I work in the hospital, and I find it hard. I don't carry an iPad around, and I find it hard to be able to complete one of these forms like I would want to, because our computers are outside the rooms, and I have a mobile phone, but it just seems too small to kind of go over the form with the patient and or
So
family.
John, it's Terry. It's actually quite user-friendly on the phone because it does come up in sections. You don't see the whole form at one
Oh,
time.
okay, that's good to know. Great. And then I wanted, I guess, to ask Sarah this because we've been kind of going round and round about this at Christiana, but it's not that easy to access the DHIN, is it? How do you access the DHIN? Do you go to DHIN.org and in your Google when you're on Cerner, or do you have a direct link to the DHIN?
I don't believe we have a direct link, or if we do, I don't know about it. So I just Google DHIN.org and access it that way.
I have the DHIN on my frequently used links.
Yeah.
On my portal, and that's how I get to it pretty easily. But we actually also have a direct link in the community health record. So if you're working at a place that has a link to the community health record, you can get to the DMOST registry through that pretty easily, just for your own knowledge about that.
That's great.
Excellent.
One other thing I wanted to comment on, something Dr. Matthews said that I think we need to be a little bit careful about, and that is the DMOST is not a form by which you can make an authorized representative. So if you don't already have an authorized representative, the DMOST form will not make the person you put on there an authorized representative. That has to be done through an advance directive that is witnessed. Just from a legal standpoint. So be careful about that. If a patient verbally says, I want so-and-so to be my decision maker, the legal standard for that is it has to be documented in the record and witnessed. And obviously the paper, the statute for authorized representative is the advance directive statute that requires 2 witnesses on an advance directive. But the DMOST is simply for recording who is already an authorized representative or by default a decision maker. Does that make sense?
Yes. Sorry if I added any confusion there.
I'm sorry, I probably confused it more, so sorry about that.
I actually think that was excellent clarification. This is an addition to and not in lieu of having that representation.
Right, and that's one of the reasons why you would want an advance directive and a DMOST. Exactly.
Absolutely.
And then my final comment was that the National Post is working on a standardized form that they would like states to eventually adopt. So once we get this steering group reconstituted, I hope to have that group look at this form and talk about how it resembles the standardized form and how we might move it more in that direction possibly. So
perfect.
For the future.
I think that's excellent. I want to thank Marie Lupone for her comment regarding her usage of the paper forms when she was at St. Francis. I think that the nice options here are you can do whatever you need to do. Her cell Wi-Fi coverage was a little spotty there, so she just chose to do them in paper. Before we end the meeting, and it looks like we are right at 6 o'clock, I'd like to ask if it's possible to send everyone who attended an email with the committees. There is an education committee, and if you are interested in working with Eddie or Delaware Hospice and taking this presentation or learning more about the DMOST so we can further educate those who were not able to join us tonight, we would love for you to participate. And it will be an overview of the committees available. If there's anything in there that you find interesting to you, that speaks to you, please contact us back. And with that, I think we end a very robust evening. So thank you, everyone. We'll be sending you a link to the recording as well as that information. And I appreciate the attendance. Have a wonderful
Thank you
night.
for the emceeing, Alex, and thank you everyone for attending. Thanks to Sarah and Nicole, and have a good night.
Thank you.
Night.
Thank you.